as we know, virtual wards are very much a hot topic. It came out of COVID and home oximetry, and now the NHS has set what they describe as a national ambition of 40 to 50 virtual ward beds per 100,000 population by the end of 2023. And at a minimum, the ICSs have been directed to set up virtual wards for frailty and acute respiratory infections. And there's lots of money available. There's 200 million available from the Service Development Fund. This year, there's a further 250 million on a match funded basis from 2023-24. Though I note there's actually no ring-fenced funding from 24-25, which I think is a reason why we need to kind of prove ourselves in this arena, that this initiative is going to work. And when you look, there's increasing support and guidance from NHS England and NHSX, but it's pretty high level. And it covers things like staffing and out-of-hours cover and responsibility, but generally from the perspective of setting minimum standards rather than giving information that's really specific. And I'm sure that will come. But in the meantime, I think there's absolutely no substitute from hearing from somebody who's done it directly. And in that sense, I think we're really lucky to have Emily with us. We'll talk more about it. But what Emily and her team have managed to achieve at Norfolk and Norwich is extraordinary, given the pressures of the pandemic, and how they've managed to expand their virtual ward to make it really a viable clinical service for most medical departments. It's a fantastic thing and a wonderful model to emulate. So Emily, let's begin at the beginning. What brought Norfolk and Norwich to launch a virtual ward?
Thanks, Matt. Well, actually, back in March in 2020, I'd actually started it within this role. And one of the first projects that were given to me was about 60 remote monitoring kit by Current Health. And the ask at that time was, well, what can we do? How can we limit the number of times that clinicians are going to need to attend to patients directly, thinking back into that sort of really height of COVID. So that's what I started to do. I was looking at the kit, looking at how I could use it. As quickly as that came along, obviously the first wave seemed to dip, and then it was like, well, I could already see where we could use this kit outside of the acute, but to support the pressure that we had on the trust. So at that point, we did a pilot actually within our NNUH at home service. And essentially what they were doing was providing IV therapy to patients in the community. And I could see how we could expand on that scope with using the kit to be able to monitor the patients that may be at risk of sepsis, for example. So during that time, we were able to really get our hands on the kit, see what patients thought about it, test it, get staff feedback, and also respond to Current Health about what we thought they could improve upon. And then came the national ask in February at the beginning of last year, 2021, that every trust should set up a COVID virtual ward. And we were just in a really good position to do that at pace. At that point, we then also designed our standard operating procedures, our business continuity plan. We'd agreed what the plan would be if the kit went wrong and we needed to return it, and how quickly, and all of that kind of thing. So when the ask came out, we really just needed to get together and decide what were we planning to do, what did we want to do with our virtual ward. And there was 3 of us originally, so myself, Ed Prosser-Snelling, who's the CCIO, and Sheila Glenn from an operational perspective, who got our heads together. And we really were strongly felt that this was going to be an inpatient model, and therefore it had to be 24/7. And then it was about how are we going to do this? What's our staffing model going to look like? And how are we going to make sure we've got that clinical oversight so that it's safe? How are we going to refer in? What's our inclusion criteria? But one thing we did know, that we were ready to take it beyond COVID, because we'd already tested the process. So absolutely we could get it in place for COVID, but we had ideas already to take that further.
I mean, that's fantastic. And one of the things that you allude to there, Emily, is obviously that disease didn't stop during COVID. We were all so focused on treating it, and rightly so, but there was all this ill health, and particularly chronic disease, that was building up in the background. So the fact that you were able to take the virtual ward and move that into these other areas in such a sort of agile fashion, I think is is fantastic. And you touched on a number of subjects there that I think are crucial, things like staffing and oversight, and we'll come on to those. But let's begin with the patients. So what patients are you treating in this model? Like who's involved?
So originally, obviously, it was COVID and respiratory naturally, but before the ask, we'd already sort of started conversations with oncology. And so our natural next pathways were with oncology and palliative care. So for example, having patients that would ordinarily have had to stay in the hospital while we worked on their analgesia and make sure their pain was controlled, we could get them home sooner and be able to manage that remotely. One of the things, because all of our patients are inpatient still, be it at home, we had access to all the hospital systems that we currently use. So we use EPMA for our meds management. So we would still do that. We would prescribe the medications if we needed to make changes, all of that we could do remotely. And then it's kind of just snowballed of the noise getting out there really, and people then coming to us and going, could we use you for this? How would this work? And it's expanded. I mean, I think we're at 13 plus, I say, pathways, because it is ever changing, and we've still got areas that we want to look at and focus more on.
Again, that's fantastic. And I think I've always felt that areas like oncology and palliative care are kind of natural homes for virtual medicine, because these are complex patients with high degrees of need who want to be at home and are best off out of the hospital. And it gives you that opportunity to not just support the parent, not just support the patient, but their carers as well, and those around them, and to reassure them. Let's just dig into some of the things you said there. So a typical patient who's coming in from one of your pathways, who refers them to the virtual ward? And do you have inclusion and exclusion criteria as to who makes it through?
Yeah, absolutely. So essentially, anyone can refer in. That we do a nice referral that the team will receive. What we do is we have team members on site that will go and review that referral and assess the patient and make sure that they accept to come onto the virtual ward. And then from there, if it's a new pathway or a pathway that we haven't introduced yet, what we do is we have an onboarding template, and within that we identify who the consultant lead will be, what the inclusion exclusion criteria is for that particular pathway, and that helps, and we have that for every pathways, but we can build that, because often in the beginning it was the patient that drove the pathway rather than the other way round. And what we know then is what the parameters are. So with COVID, that was easy. It was a clear understanding that if the SATs dropped below 92%, there was a plan in place, and that's what we did. With the onboarding for different pathways, it means we can make that more bespoke. And within current health, we can also make the alarm parameters bespoke, so that it again, respiratory is a good example of where it may trigger at a lower level for someone with respiratory disease than with somebody who hasn't. So we're able to do that.
Again, there's some really interesting things in there, Emily, because I guess what you're talking about is that complete picture, isn't it, of someone being referred, someone being monitored, and then having that capacity to escalate them back into the physical inpatient service if anything goes wrong and there are set criteria. Could you perhaps give an example of the, say for any pathway you like, some inclusion and some exclusion criteria, like what kind of things you use to differentiate these patients?
Yeah, absolutely. And actually in the beginning, we had our exclusion criteria included patient groups like with dementia, learning disabilities, because we were concerned that they wouldn't be able to manage with the kit itself, even though it is simple to use. But what we found as it evolved was that the less exclusion, the better, because it was better for us to review the patient and look at their needs and how they manage at home. So with those groups, actually, patients with dementia and learning disabilities are the ones that would benefit more so from being at home than being in hospital, because as we know, it makes them often more disorientated and confused. And also they often have some support with them, and therefore the carers or relatives could help with keeping the kit on, and that's worked really well. So actually, where we started off with a larger exclusion, that's definitely got smaller, and then from there on, it is on a case to case or pathway to pathway basis on what that would look like, but it generally is around the kit rather than the actual patient themselves.
Yeah, no, I mean, that's interesting. Certainly at Current Health, for some of our other clients, we've developed pathways that have inclusion criteria really just to drive referrals, so people understand that the virtual ward is an option, and so that we usually keep them quite broad and quite generic. And then we have exclusions that really are to pick out people who are too sick and
Yes.
too well.
Yeah,
and I
yeah,
imagine it's the same.
absolutely. So like I said, with ours being inpatients, if they can go home, we facilitate that. And quite often when we're asked to go and see a patient, we actually facilitate them to go home as a discharge rather than transfer onto the virtual ward. Yeah, absolutely.
So your ward is very much, it's an inpatient ward where the in bit is home. Like, it's if they can be discharged, they are. There's not a step down. This is not a kind of halfway house. This is a ward.
Absolutely, and we're really clear on that. Of this is not a safety net of those kind of that you think, oh, I'll just keep them on over the weekend on the virtual ward. It's like either they need to be in an acute bed or they don't for us, which means that our numbers are more realistic. Of kind of I know that they're genuine figures of patients that would have been in the hospital ordinarily.
Yeah, no, that makes a lot of sense. And I suppose the flip side is when we exclude people, it's because they are unable to use the kit, which, as you've said, is turning out to actually be a smaller and smaller number of people.
It really is,
it.
yeah. And or they need to be in an acute bed for the additional care that they require.
Yeah, or inpatient investigations, things like that, because it obviously defeats the point if they go home, come back, because that's the kind of dislocation that we're trying to avoid.
Yes. Yeah, and actually on that, we set up a couple of pathways. We ended up leading like an awaiting for pathway. So it's like awaiting for diagnostics and awaiting for treatment, where actually they could wait at home pending that diagnostics. Whereas we know that if we discharge them home, they wouldn't get that. They still need it to be done quickly and not as an outpatient, but they don't necessarily need to be waiting over the weekend, for example, for an ultrasound.
And that's quite a profound point, isn't it? Because we've all, when I was working in hospital, particularly as a junior, you find yourself in that position where you're like, well, we should kind of keep them overnight because then they'll get a CT scan. And that's just such a terrible waste of resources.
Yeah, absolutely. And that was, again, one of our sort of earlier finds was that there is this group of patients that are in beds just waiting for something. So waiting for a diagnosis or a test or to go somewhere. And this was a better place for them to be. And they wanted to be. That's the other thing.
Yeah, no, that's the thing. I mean, one thing we know working in hospital is you only really want to be in there if you're paid. So there's definitely yeah. If you could be home, you want to be home. I mean, are there any particularly memorable patients? Like, is there a patient story that really springs to mind when you think about the service you've provided?
There's just the ones in the beginning that I really think about is when we started to get patients home that were palliative, and there's some really sad stories behind that, and the last place they want to be spending their sort of last days is in hospital. So getting them home was really rewarding, and getting them the care that they required. And another one is actually we transferred a lady straight from clinic who required IVs, but she was breastfeeding, and again didn't want to bring a newborn in. We were in COVID, like the last place anyone wants to be, and we were able to support her on the virtual ward. Now that wouldn't have even been an option 2 years ago.
That's a great thing. I mean, breastfeeding is an interesting example. Like, we've just completed a study in another hospital where we look at the acceptability of wearable devices for breastfeeding mothers, and they do really like it. In the 24 hours post-cesarean section, when you're trying to get them mobilized, trying to get the baby fed, trying to get them some sleep, like having something that's relatively unobtrusive seems to be a big help. I suppose let's come on to the tech then. So use Current Health, which is our lot. I'm sure other tech is available. But would you like to tell us a bit about your perspective of it? What kit do you give patients, and how do you find it?
Yeah, absolutely. So the kit we use is the Generation 2. It's a really small wearable. One of the things that I will say that, you know, from when we were the first kits that we produced and moving on to the Gen 2, such a difference in the size, and that's because of the responsiveness really of the company to listen to what we were saying to them. So the device is really small. It's a really comfortable strap. No one's ever complained around it. They understand it, and the fact that it comes in a small box that we can decontaminate easily between patients, and has clear guidelines for patients to be able to use it. There's the tablet that we do the video calls. So we would do daily, or at least daily, video calls with our patients that they can also send a message if they need help, and we can respond to that via phone or via video call. We can use it to push questionnaires to the patients that might be around pain or blood glucose or something. And then we also have blood pressure cuffs, which might not go out for all the patients, but if it's a patient that requires it, we can also add that on. And we do have other peripherals available to us with spirometry and scales that we can use also. So we tend to kind of give out what they need, and sometimes they don't need any of the kit, and sometimes they need the full caboodle. So that's what we tend to do.
Grand. So yes, at the core is this Gen 2 wearable that measures your kind of basic observations you get in hospital. So heart rate, respiratory rate, SATs, skin temp, movement. And then what you then do is you have specific peripherals really for specific pathways. Is that right? So
yeah,
if you're blood pressure pathway, you get blood pressure cuff.
Yeah, exactly that. Just it makes it easy for us to then give out to the patients, and what we then can do is we view from the clinical dashboard, and we can do that from our phones, from our trust laptops, and we can look at so I can log in now and look at all the patients on the virtual ward, what their observations are doing, and also that's where we document the notes, so I can see who last saw them, you know, if the doctor's seen them, what happened on ward round, if the drugs need changing, and all of that within the one system.
Grand. So yeah, so there's a kind of workflow enabler there, and it's also kind of an audit trail as well, I suppose.
Yeah, absolutely. And because it also shows, it triggers when a patient's observations goes out of the agreed parameters, it'll send a notification, and then it will show what the response was and who picked it up. So it's absolutely a full audit trail of everything that's happening with the patient.
And one of the things you mentioned there is alarming and alerting. So obviously if the monitor doesn't go off when something goes bad and no one's listening out for the alarm, those are two separate and important steps in that chain we talked about at the beginning. So to start with the alarms, how do you tend to set them for your patients? Do you start with a default and alter, or what's your process?
So for each pathway, we agree the parameters, but then if there's a patient that we need to change throughout, you know, outside of that, we can do that within the system. So we can do it on a patient to patient basis. We can also silence alarms if we know, for example, that they've taken off the kit because they've gone to have a shower. Then we can mark that on there. So yeah, it's just really easy for the team to use. And one of the things I was concerned about in the beginning, that as a nurse, are they just going to be glued to this laptop and just staring at the observations and waiting for there to be a dip? But actually, it just doesn't work like that. And the kit, luckily, it notifies them, and that means that they can be doing everything else around that patient that they require to do. So booking transport for them to come in, getting a swab, organising team to go and take bloods, whatever it is. Yeah, with the notifications, it means that they know what's going on.
Fantastic. And that, I guess, brings us quite naturally onto staffing. So when you sort of established the virtual ward, how did you begin staffing it, and how's it grown since then?
Yeah, well, so in the beginning, again, height of COVID, we actually got a group of 6 shielding staff who all worked remotely. So my original virtual ward team, I never actually got to meet in person until a couple of months down the line.
That's amazing.
But the great thing was that they were at home shielding knowing everything that was happening in the hospital, but not being able to help. And so when I put a plea out to say, look, we've got this new initiative, we're looking to do this, I'm looking for people that would be interested to help, we were inundated. It was so lovely to have nurses, AHPs from across the trust coming to us and going, yeah, I'd like to be a part of this. So our original team was 6 shoulders, and then we had 1 operational lead who's a 8A on site. So that person needed to be able to go into we had the red areas, the COVID wards, because that was where our patients initially were coming from. And what their role was to do was to respond to referrals, identify patients themselves, assess them and make sure they're suitable for the ward, and then communicate that through to the team, who would then obviously oversee their care. And they were that kind of senior support, and also part of their role was conversations out there about what the virtual ward was all about and getting all that engagement. And then from there, we introduced a virtual ward manager, so a band 7. And that basically, that staffing model was suitable for 24/7 care for 20 beds. We also have a consultant lead who oversees, and they put together a roster of consultants who would attend the ward round every day, so that we had that oversight and escalation as well. And then since then, we've now moved to increasing our bed base to 40 beds, and we've just recruited a few months ago an additional 2 band 6s. So we really do replicate a normal ward, but with less band 5s that you would require for ordinarily for 40 beds. And those band 6s means that between the 6s, the 7 and the 8A, they're on site doing that engagement, that drive, that pulling the patients through the service, because as we're expanding on the pathways, they've got a lot more ground to cover.
Yeah, no, I can imagine. I mean, one of the things you said at the beginning there is the opportunity for shielding staff during COVID. I went back to ICU for COVID, and I was so actually happy that I just had somewhere to go and colleagues and people to see and a job to do, because sitting on my hands at home, I think, would have been a bit grim. And so I can imagine for shielding staff to be able to contribute alongside your colleagues in a way that befits their own health needs.
Yeah,
must have been quite profound for them, actually.
Yeah, it was, and actually 2 of the staff stayed on with us, and the remainder often do bank. So they are like the original group. And one thing I have found with the team, it's just a really enthusiastic pleasure to work with team, because they've chosen to be doing this work, which is quite different, and they find it rewarding, because that time that you can have with the patients that unfortunately we're not always able to get in that busy ward setting when you've got your bells going and the phones going, and actually they're building up one-to-one relationships with the patients on the virtual ward, and I think from the patients and the staff, that's been really rewarding and beneficial.
So again, that's interesting, because you'd think if you're interacting someone through a digital medium rather than at the bedside, the quality of relationships that you would build up with your patients would be less or more superficial. But from what you're saying there, actually, it gives you the opportunity to spend time with someone in a very focused way.
Yeah, it actually almost feels more personal. And I mean, I'll be the first to say, in the beginning, I was concerned, are we going to de-skill these nurses? Because again, like I was saying about just responding to alerts, but actually they're almost like general practitioners for the virtual care, because they have to understand everything that's available to them within the hospital. And then, with the patients, I've heard stories like where, on the ward, they might have been having trouble with their bowels, but with curtains around them and in a bay of 6 patients, they didn't want to be talking about it. So when actually they've got somebody who they trust and they're talking to, and they feel that they can say, what, also just to let you know, it's not why I'm on here, it never is the reason that they're on there, but they can share that information with the nurse, and the nurse can respond and do what is required to help.
I mean, that's just that point about privacy is really interesting, because we've all been in that situation in hospital where you kind of draw the magic curtain around the bedside and suddenly everything in there is supposedly secret. But as we all know, everyone on the ward knows everything that's going on with everybody. And actually, to really have true privacy, I think it feels first and foremost more respectful, but also I could see that it would actually lead to more open conversation. So yeah, that's a great thing to hear, and something that I'd not really considered before. So just to kind of sum that up then, so you've got on the nursing side, you've got one band 7, and then just talk me through the numbers.
Yeah, so we've got 1A, there actually are they're nursing clinical, 1 band 7, 2 band 6s, and 6 band 5s.
Great. And that allows you to do 24/7 cover, 365 for 40 beds.
Yeah, and then
It's
what
quite
we
efficient,
do.
actually.
Yeah, and then what we do is we have a number of nurses trained on the bank. So if we have times of flex or pressure, we can actually then it may be, and this is where it's so unique. Where if I asked you to come and do a bank shift this afternoon, you'd be thinking, oh, now I've got to pick the kids up from school, or I can't do that. Actually, with virtual ward, you could open your laptop and do 2 hours work before the school run, and that's really supported us, and that's what we needed to get on top of the phone calls or whatever it is. And so we do have a number of staff trained on the bank who we can pull in as required, and that's where it'll come into his own in winter pressures and hopefully not, but any other future waves of COVID.
Well, I mean, that's a great thing, because I guess then, so you've trained your staff, they then go onto the bank, and that's quite nice, because people may not want to do virtual nursing forever, and so you can have a spell of that, and then this is an additional option for you.
Yeah, and we don't have to stick to the sort of traditional shift patterns, because actually it might be in the afternoon that we require more assistance, or into the evening like a twilight, but it doesn't have to be set time periods, and it makes a much more flexible service to suit the needs of our patients and what we need to do to make it
Makes
work.
a lot of sense. And so that's on the nursing side, and you said you had a consultant lead on the medical side. Who else do you have on the kind of medical and allied health professional side?
So currently that roster is made up by the clinical lead, by some very, very supportive and voluntarily giving their time consultants, as are these things when you're bringing them together. The plan long term, we've got a business case underway at the moment, will include PA time for consultants. They'll have more dedicated time. Part of that will be around the size of the pathway that they may be responsible for, and looking at it in a different way.
That makes sense. And one of the other points that you mentioned earlier was around training and expertise. And it does strike me, seeing what you've done and others have done in the UK, and also some of the deployments in the US. We've got our own kind of clinical command center in the US, where we have professional virtual ward nurses. And it is a specialization. There is an inherent skill to doing it well, and there's an inherent personality of people who are kind of good at doing that job. How do you train people, and what do you think makes a good virtual ward nurse?
So actually, a lot of the training, less so now, we can actually get on site. It has been done remotely, and it's worked really well. Like I said in the beginning, the Shielders, all of their training was totally remotely. But there's nothing quite like getting your hands on the kit yourself to have confidence in talking about it. So now it's a bit of a mixture, really. Our band 6s have just put together a student handbook, like you would have on the ward, of kind of like an introduction, welcome to the dot type thing, like a student handbook, but for new people joining us. And I worked with the national team to develop some e-learning for virtual wards, and what things to look out for as well. That's also available. So we kind of tap into a lot of things. Current Health been very good with supportive of helping with training, but often we can disseminate it quite easily within the group. And then what makes a good virtual ward nurse is, I think it's often, I don't know, it's like a unique personality of just getting what it's all about. I think that passion for ensuring that the patient is cared for in the most appropriate place, whether that be in the acute trust or at home. You don't need to be techie, but you do need to have a degree of sort of ability to be able to use the system. But we can train that through, and it's not a complicated thing. It's just about accessing and logging into the dashboard, essentially, because a lot of it with the patient putting their own kit is so self-explanatory itself. So I think it's more around just the passion for understanding why we're doing what we're doing.
Yeah, so believing in the model. And I guess also, I mean, it does really strike me as a skilled thing, because we rely so much in hospital on just looking at somebody and reassuring yourself. And here, I guess you have to build up a mental context of where the patient is in their home life. And that seems a very skilled thing.
Yeah, you're right. And actually, it is again about building up those relationships and getting to know, like, oh, you don't seem yourself today, that kind of thing. But also the dashboard itself, you get to learn like trends in it. It's quite strange, where you think you're just going to respond to notifications and things. You're looking at a whole different kind of holistic picture than you would be when you're looking at a person in a bed in a hospital.
That's really interesting. And it's one of the things that impresses me so much about the setup that you have is that you generally catch a deterioration in a patient before an alarm goes off. And I know we've set your alarm parameters. Because of that, we set your alarm parameters actually quite broadly compared to people who were new at what they would do, because you guys have this intuitive nursing sense of when things might be about to go wrong. And I know there's a few patients you've caught, isn't that right?
Yeah, I mean, because you kind of think readmission is like an emergency situation, you bring them in, but often what we've done exactly that, is be able to catch something, bring them in, do a bloods, give them a review, whatever it is, and actually send them back home again, because we've been able to either explore that what it is, or treat it, and can continue on to the virtual ward. So even though they may be like sort of readmitted for a period of time, it's not necessarily an emergency readmission. And what we're able to do, because they're inpatients, is they don't have to come back through A&E and go through all of that system, that actually we can get them to the most appropriate care for what they need. And that makes a real difference as well.
So that's actually a really important distinction that I think it's worth dwelling on, is that your patients are inpatients. And it sounds like that's been very enabling, because it gives you access to services, it gives you access to information. But presumably to this point, you're also not, quote unquote, punished for them coming back, because what you've really done is just move ward.
Yeah, I mean, I was really clear from the beginning that they would need to stay and be transferred onto virtual ward and discharge, because otherwise it affects all our reporting, our length of stay. If we're saying they're discharged but we're looking after them, why are we looking after them? How we get paid? So it just, for me, would naturally needed to be a transfer onto the virtual ward to keep all of that process running in the way it would need to.
Yeah, because one of the challenges, isn't it, is capturing what you just described, that process where you have somebody on a virtual ward, you catch a deterioration early, you bring them in and preempt something that would have been much worse, much more expensive. To actually capture that as a saving is very difficult in terms of metrics, isn't it? But actually that's the true value of a virtual ward.
Yeah, absolutely. And it is difficult capturing the true value, as you say. I'm sure there's other trusts out there working on their business cases and that, to really prove what caused what and how it is affected. But it's the positives just are really quite clear to me.
Well, now we've clarified the positives, let's talk about some of the challenges, because I know there've been some. What challenges really spring to mind for you in what you've been able to set up?
I mean, the main challenge was going from a COVID virtual ward to a general virtual ward, and so dropping that COVID bit really early on. We were keen to do that, and just making sure that teams knew what we were and what we weren't. And I think that's the biggest thing. And I think, there are virtual wards existed in the community for a long time. I hear that a lot, but actually it's not the same thing. So really getting out there what the definition of the virtual ward and our virtual ward is, and how we can help. And I think the biggest concern, and rightly so, through COVID was, is this going to be extra work for me? Because what you're doing is you're essentially increasing the bed base. And therefore, people then are asking, well, hang on a minute, I've already got this many patients, why would I want to take more? And it's for them to recognise the greater good for the patient, obviously, but also that the virtual ward team aren't just going to escalate everything directly to the inpatient teams, because actually a lot of it they can solve and manage themselves. So through the process, it's just about almost just slowly just drip feeding all the good things that have happened. Obviously, we've been nationally recognised. We've done many comms pieces, and it's just working through and engaging with people, and we're getting new pathways and things all the time. So it is happening, but it is a challenge.
Yeah, no, I can imagine, because you really can envisage that, can't you? That you have clinicians who are stretched beyond what they felt their maximum would be for such a sustained period of time, and suddenly you say, here's 10 more people. And so what you're actually, the message that, from what I've heard there, that you're trying to get across is that, no, they've been moved to another service, like where they're looked after. If we need your help as a specialist, we will ask, but they've been moved to another service.
And because we have that onboarding template and that understanding of what we're looking out for whatever reason, we can do that. And I think also it's not often 10 patients because of the pathways we have. They might be like, oh no, you wouldn't be in, I've got this kind of group of patients, but actually it's only one a week. And it's like, one a week, that's fine. So from their perspective, actually it might not be huge numbers, but I think there's this kind of perception of, well, you won't be interested in that, you're just looking for big numbers. And it's like, no, it's about any patients that don't need to be nursed within the acute setting. If we can facilitate, if it's one a month, it doesn't matter, because they all add up. So that's part of the challenge as well.
Yes, if you have 40 beds, but you're just taking from the extra overload from each specialty, it doesn't trouble that specialty, but you have a full and successful ward.
Yeah.
So I guess if you were to advise anybody on setting up a virtual ward, in response to some of the directives that we mentioned at the beginning, are there any golden pieces of advice that you would share?
I would definitely say, in the beginning, we just brainstormed, what do we want? And we went bold with the 24/7 model, and, a lot of trusts go, because of funding and but we were just going to ride the wave at that point and set out what we wanted to achieve, almost like go high. And sometimes, you get bid down. So my advice would be stick true to what you really think it needs to be. Because otherwise you end up potentially compromising the service. So just be bold with your decisions, think of the pathway end to end. So making sure that referral process is really easy for clinicians, making sure that you've got that kind of clinical oversight, because that's part of it. They need to be assured that this is a safe system, that's what I'd probably do, and lots of comms.
Yeah, that's one. And so, I mean, as we said at the beginning, the money's out there. So you're saying be bold and use that money to good effect. I mean, chatting to you, Emily, and having known you for a little while about what you've been able to achieve, I think the other thing that strikes me is just the huge importance of having a champion, having someone like you with energy and vision who can take these things forward, advocate for it, and really make sure that it gets embedded into the trust.
Yeah, absolutely. And I think you hope that that then rubs off on others and they become champions for you, and they go and go off and do it. And there's some amazing people across the UK that are setting up great virtual wards, and we're all learning from each other. So it's really positive.
I mean, that's great to hear. I mean, the reason why I work here is because I believe in this. I do think it's going to help the NHS with the pressures that it's under. And so it's lovely to hear how well it's been working for you, and how it can be done so well. What's next? What are your plans for Norfolk and Norwich?
So next, as you say, there's obviously some national funds. So we've just put in a bid for across Norfolk and Waveney, looking at how we can expand on what we've been doing, and also, as you said at the beginning, around the frailty and respiratory, and what our pathway would look like to have a step up, step down to the community. Our ultimate ambition is that wherever you are in Norfolk and Waveney, you have equal access to the care that you need, whether that's in an acute bed, in an acute virtual ward, or in a community virtual ward. And long term, we'd like that to be one virtual ward, but there'll be a phased approach to it. So that's where we are at the moment. So fingers crossed.
The one ward to rule them all. This is absolutely. Emily, I can't thank you enough for spending time with us now. Like, it's so evident how busy you are and how much you've achieved in such a short period of time, and made light work of what must have been some very heavy pressures. So thank you for all that you do and continue to do, and for spending some time with us.
Pleasure. Thanks very much.